Great. Thank you so much, everyone, for tuning in today. Today, I'll be talking about Indigenous Pharmacogenomics and implications for personalized medicine. Just a little bit about me. I am Katrina. I'm at the University of Colorado, as Larry mentioned. I would like to start by acknowledging the original occupants of the Denver, Aurora area, which the University of Colorado sits upon. These are the traditional homelands of the Apaches, the Ute, Cheyenne, Comanche, and Arapaho tribes. So today I'll start with some background about personalized medicine and pharmacogenomics. And then I will talk about pharmacogenomics in relation to nicotine metabolism and smoking cessation. And then lastly, I'll end with thoughts and perspectives on how we can do research in partnership with Indigenous peoples. So oversampling of European descent populations in genetic research can bias our understandings of which genetic variants are important. And this might result in medical advances that are beneficial for people of European descent and not the world's population as a whole. In one of the latest analysis in 2000, I think this is from the 2016 paper, it showed that about 19% of samples included in GWAS studies were non-European ancestry. So this was an improvement from 2009 when there were 4%. But this increase in diversity was mostly due to Asian ancestry, which made up 14% of the 19%. When we look at Native peoples in this pie chart, they are about less than 1%, so 0.05%. And this number has been getting a little more accurate over the years, and the number of Native peoples involved in genetic research studies has just been lowering every year. But genetic studies also lack other historically underrepresented populations, and many of these populations experience healthcare disparities and health disparities, and if they're not well represented in the future, new healthcare inequalities could arise. So within the field of pharmacogenomics, we aim to establish how genes affect a person's response to drugs. Pharmacogenomic research guides the selection of the best drug and dose for an individual, and it's predicted to reduce the cost of care by increasing efficacy and minimizing adverse drug reactions. So if we take a diverse population, such as in this figure, we can stratify individuals into different subgroups who have different or similar phenotypes. So the purple and red individuals on this figure could represent poor metabolizers or extensive ultra-rapid metabolizers, and the blue figures could represent people who you would give the regular prescribed dosage of a particular medication. So by enhancing our understanding of genomic variation and how it relates to drug response, we hope to be able to better incorporate genomic data to predict better medical outcomes and optimize the quality of care for patients. So it's been my pleasure to be involved in various pharmacogenomic research studies in partnership with Indigenous communities. As a postdoctoral fellow, and currently I still work with the Northwest Alaska Pharmacogenomics Research Network, which addresses pharmacogenetic research within American Indian and Alaska Native communities in the Pacific Northwest. So the NWA-PGRN has a diverse team, including investigators from various universities, as well as university research partnerships to identify potential barriers and facilitators for the use of pharmacogenomic research. And at its core, the NWA-PGRN uses a community-based approach to working with tribal communities. In addition, I was also recently awarded the Genomic Innovator Award from NHGRI, and the main focus of my research program is establishing partnerships with American Indian and Alaska Native tribes and other Indigenous peoples, and thinking about how we can advance ethical research practices and form frameworks that center on Native research and capacity building. So I'm very excited to expand this work and work with new tribal partners and continue my work with my current tribal partners. So when we think of adverse drug reactions, genetic variation is responsible for about 30% of those adverse drug reactions. So it's really important to have a complete picture of genetic variation, both common and rare, and how this can affect a person's response to medication. And a person's response to a drug is often, and most times, linked to their genetic variant profile. So of all of the drugs on the market, about 75% are cleared by drug metabolism. In particular, the cytochrome P450s shown in this figure are responsible for up to 75% of drug metabolism. And so this is a main focus of my research program, in which we look at cytochrome P450 enzymes shown here in the figure B. So these are often referred to as CYP genes. So CYP3A4 and 3A5 are actually responsible for about 40% of drug metabolism. So a couple of years ago, my colleagues and I were able to review all pharmacogenetic studies in North American Indigenous tribes. We currently are very deficient in knowledge about the association between genotype and phenotypes in Indigenous peoples. So we identified 27 studies of Indigenous peoples in North America between 1990 and 2017. In this survey, we looked at 11 cytochrome P450 genes. What we found were 6 studies that were conducted in American Indian and Alaska Native peoples. Most of these studies actually came from the Northwest Alaska Pharmacogenomics Research Network, in which I was a postdoc with. In Canada, the Indigenous peoples, there were about 7 studies that involved Indigenous peoples of Canada and 14 in Amerindian populations in Mexico. Oops, there seems to be a slide that my slides are just going ahead without me. But what we found is that the allele frequency between populations were highly variable, and there was really no consistent similarity to frequencies in other ethnic or racial groups. So this is just one example in the CYP2C19 enzyme. So this, I'm showing the STAR2 variant, which is an allele that causes a loss of function in this particular enzyme. So the frequency of CYP2C19 STAR2 is shown in this table. And when we look between First Nations, United States, and Mexico Indigenous peoples, we see that there is high frequency variation and in this loss of function variant. This just demonstrates how isolated populations can have unique genomic variation, and this can happen for multiple reasons, such as the founder effect, different selective pressures caused by the environment, or even genetic drift that can cause extreme frequency variations between populations. But these assays in particular populations might have missed variations if they only genotyped these particular genomic variants, and the clinical implications of unknown variation is becoming more clear. So this is just one example of how we can apply pharmacogenetic information. This is an example of 2 randomized clinical trials that assigned patients to a pharmacogenetically guided warfarin dosing based on 2 genes, VCORC1 and the CYP2C9 genotype, or they did a fixed initial dosing. So within the first group, the EU-PACT, they found that there was a benefit in using genotype-guided warfarin dosing. In the other group, the COAG group, they found no significant difference between the 2 groups. So why are we seeing these conflicting results? Well, when we look at who composed the patient population, the EU-PAC was primarily European descent populations. In the COAG group, there were 27% African-American individuals, and it's well known that African-Americans have lower frequencies of the CYP2C9 star 2 and star 3 alleles, and these were the only CYP2C9 variants that were considered in this pharmacogenetic algorithm. So it makes sense that we're not including enough variation from other populations. So one can imagine using genetic variation for selective treatment to optimize care based on interethnic differences in drug disposition. Some treatments may be better in certain populations, but aren't used because they haven't been characterized, especially in native populations. This leads to a potential for phenotypic misclassification and might contribute to healthcare disparities. There are also missed opportunities for optimizing care. So there really is a disconnect between what the public perception of the genetic code for race and scientists who do research on ethnicity and medicine, because it can influence health outcomes. So many of you have heard of personalized medicine or precision medicine. It's definitely been a buzzword in the genomic field for the past couple of years. So personalized or precision medicine aims to understand how a person's genetics, environment, and lifestyle can determine the best approach to prevent or treat disease. And you may have heard of many initiatives, some of which are the All of Us initiative and other biobanks, which are trying to characterize variation in populations and return these to patients and incorporate their information into healthcare. So this is also one initiative that the Colorado Center for Personalized Medicine Biobank, in which I'm faculty, is trying to do. But I do want to say that one of the foundations of personalized medicine is pharmacogenomics. So many people have thought of pharmacogenomics as the low-hanging fruit in personalized medicine, but it's really not that simple, especially when we're trying to reach diverse populations and implement this into clinical care, which is actually one of the most difficult problems. So my example is studying nicotine metabolisms in American Indians and Alaska Natives, and using personalized medicine as a tool for smoking cessation. This is important because we can understand the mechanisms of cigarette smoking and the causes for lung cancer in this population, but also inform pharmacological treatment decisions for smoking cessation. So I'll switch gears into talking more about nicotine metabolism and personalized medicine. So within American Indians and Alaska Natives, they have a higher tobacco use rate than any other racial or ethnic group in the US. Tobacco use is the leading cause of preventable death in the United States. So as you see here, it's about the prevalence in smoking is about 40%, but few tobacco cessation interventions are tailored to community needs. So looking at pharmacogenetic testing to tailor tobacco cessation treatment might improve the cessation rates in the Native community. But it's important to recognize that there is also heterogeneity in cigarette smoking prevalence in the United States. So this is just showing a map of the United States and some of the different regions. And in the figure, I'm showing the prevalence of smoking. So from Alaska to the Southwest, you can see that there is a difference in smoking rates. And it's important to recognize that there are 574 federally recognized tribes in the United States, and each has its own relationship with tobacco and cigarette smoking. So American Indians have the highest rate of tobacco-related disease and death. So if you look at the same regions, and here we've added lung cancer mortality in Native peoples and white people, and you can see that by far in almost every population, there is higher lung cancer mortality in Native peoples. So when we think about the genetic background of nicotine metabolism, many people have looked at genome-wide association studies, and the strongest evidence for association emerged near the CYP2A6 enzyme. So this is a gene in the cytochrome P450 family. Since then, this has been replicated in other populations. So there is a high heritability of nicotine metabolism, so about 60 to 80% heritability. So nicotine is the main component in cigarette smoking and the main source of tobacco dependence. Dependent smokers intake cigarettes to maintain a constant level of nicotine. And genetic variability within the CYP2A6 gene is the primary enzyme that inactivates nicotine into cotinine. So here in the figure, I'm showing that nicotine is metabolized primarily by CYP2A6, about 70 to 80%. The same enzyme also metabolizes cotinine, which is the most prominent metabolite of nicotine. So this is a pathway that that happens in most smokers and accounts for nearly 3/4 of the total metabolism of nicotine. But smokers vary widely in their nicotine inactivation and clearance. So the CYP2A6 gene is also highly variable, and differences in genotype have been associated with tobacco exposure, smoking cessation, and lung cancer risk. So some individuals might have a increased function CYP2A6 genotype, and these individuals will metabolize nicotine faster, thus enabling them to be exposed to nicotine and other carcinogens in cigarettes more. And then there is less efficacy in individuals with rapid metabolism who are trying to quit smoking, but they also have a higher risk of lung cancer. So smokers with slow CYP2A6 variants have a lower nicotine metabolite ratio relative to smokers with normal fast CYP2A6 variants. And this can be readily measured in a phenotypic biomarker that we can measure in saliva, urine, or plasma. And it's not really dependent on the time since the last cigarette was smoked. This is a biomarker that we can use to measure CYP2A6 enzyme activity. So if you measure the metabolite 3-hydroxycotinine over cotinine, you will have a measurement of nicotine metabolite ratio. So when we think about it, CYP2A6 genotype and the nicotine metabolite ratio predicts all of these relationships that I mentioned earlier. So people with increased function also have high NMR and are more likely to be exposed to carcinogens from cigarettes. So what do we know about nicotine metabolism in American Indian and Alaska Native populations? So this is a study that looked at three Native populations, the Northern Plains, Southwest American Indians, and Alaska Natives, and compared them to white and African American populations, so just showing mean NMR. So what we can see immediately is that in all the Native populations, they have a much higher mean NMR than the white and African American populations. So really, how does this relate to smoking cessation efforts? This also begs the question, why do American Indians have such high rates of nicotine metabolism? So I like to go back to this. Studying nicotine metabolism is very important, and a lot of studies have looked at this using randomized placebo-controlled trials. So we can use nicotine metabolism as a personalized medicine tool for smoking cessation. This is just one scenario in which some trials are doing this. You can separate smokers into slow nicotine metabolizers and normal or fast nicotine metabolizers based on the NMR. And then if these individuals want to quit smoking, you can give them a variety of smoking cessation options, such as varenicline, the nicotine patch, or a placebo, and then you can test the cessation efficacy and safety. So many different trials have used NMR to tailor cessation treatment, but all of these studies are predominantly in white and Black smokers and not in Native peoples. And the reason why this is so important is that just showing some work done by Lerman et al., in which they separated individuals into slow and normal metabolizers. So I'm showing three sections in the figure. The first section is right after treatment, and then a 6-month follow-up and a 12-month follow-up. What we see is that within slow metabolizers, the nicotine patch does fairly well over time, but when we look at normal metabolizers, by far prescribing varenicline actually works for these individuals much better than the nicotine patch. So I think this sort of gives us an idea of how we can use this in Native communities and why it's so important. Native communities also have various traditional and cultural values associated with tobacco. And there is a distinction between tobacco used for cultural and ceremonial purposes as opposed to the commercial cigarettes and other commercial tobacco products. So it's important to work with communities to think about how we can incorporate smoking cessation into their work. So previously, I've conducted some research with Southcentral Foundation, and Southcentral Foundation is a primary care service facility that provides services for over 60,000 American Indian and Alaska Native peoples in Anchorage, Alaska. So it's right next to the Alaska Native Medical Center in Alaska. So this partnership with Southcentral Foundation really arose long before I entered the team as a postdoctoral researcher. But I think that the way they approached this, working with the tribal community, was really unique and something that I think other researchers should do. So within Alaska, there are very diverse cultural and multiple heritage groups. And all of these individuals go to Southcentral Foundation for their primary care. So one of the initial steps to working with the community were really to explore perceptions of pharmacogenetics research in their community and smoking cessation. So this was what the first study by AVAN et al. Did. So they use qualitative research methods to enhance understanding of pharmacogenomics, some of the barriers of pharmacogenetic implementation at Southcentral Foundation, and also assess the feasibility and acceptability of using pharmacogenetics to target tobacco cessation treatment. So this is a published paper that you all can look up and explore on your own. And where I came in was sort of on these second steps where we were really interested in characterizing genetic variation in the CYP2A6 gene as well as in a few other genes and see how this related to nicotine metabolism and tobacco cessation treatment. So these were two other papers that we published, one in 2019 and one quite recently in this year. But we were able to identify the relative contributions of various genetic factors to successful tobacco cessation among Alaska Native and American Indian people. We were able to identify associations between the nicotine metabolite ratio and genetic variation in these populations, and as well as we stakeholders at the Southcentral Foundation led a study in which they enrolled smokers from the community, and they were able to follow them over time and see what interventions worked best for those individuals. So I think that that paper is in production now and hopefully can be added to this whole story. But I'm not really going to go in depth into this research with Southcentral Foundation, but all the papers are there for your reference, and they do a good job of explaining our work with Southcentral Foundation. But moving forward, I think that one of the big questions that people have been thinking about are how to, as more and more studies are pursued with underrepresented and underserved communities, how can we do research in a respectful and culturally appropriate way with Native communities? So how can we as researchers, institutions, funders, engage Native communities in genomic research? And also, as health applications are developed from genomic research, how can we assure that everyone benefits and that populations are not harmed? So I really like to quote one of my colleagues, Dr. Kim Tallbear, from the Summer Internship for Indigenous Peoples in Genomics Consortium. She says, if you're going to work with Indigenous communities on genetics, you have to be willing to make lifelong relations. And this is something that I take to heart and everything that I do in my research. And I hope that other individuals who want to increase diversity in their studies also think about Dr. Tallbear's quote here, as well as some of the work that I'll talk about next. So in 2018, well, really 2016, the SING consortium came together. So this was a consortium of previous SING alumni who were students, as well as SING faculty, and really thought about how could we foster stronger relationships between Native communities and researchers. And we developed a framework for ethical research. And this ethical framework was really to help increase trust and increase inclusion of diverse groups, as well as enhance ethical research practices. So these are just some of the co-authors on the paper at one of the SING workshops we held. So in this framework, we go through different ways. We highlight 6 principles within this framework that we think that will enhance ethical research practices. So this is the main figure in the paper, but and it's circular to represent that it's a cyclical, and all of these concepts are related. And as someone uses this framework, they should know that these principles can continually evolve as connections and collaborations deepen. So one might want to revisit capacity building, for instance, as more funding becomes available or new research questions arise, and or maybe there's a new project in which you have to go through the research oversight bodies. But at its core, I think, is recognizing sovereignty and research regulations of the communities that you're working with, really engaging with the community in the research, making sure that all researchers on the team have established some type of cultural competency and knowledge of the community, being very transparent from the very beginning about the research study and what is happening and involving the community in all aspects. And then capacity building, really trying to provide benefits and train the next generation of Native scientists who are part of these projects. And then lastly, disseminating some of the knowledge from the studies that do happen. This might, I know for a lot of researchers, the peer review publication is the bread and butter of our work, but for communities that might not be as interesting. So making sure you're distributing the knowledge from these research studies in ways that are beneficial for the community themselves. So this is one ethical framework, but in just recently, or in the last couple of years, there has been a great advancement of community-specific research ethics guidelines. And if you're working with any of these communities, I think it would be in your advantageous for you to look at some of these ethics codes. So for instance, Te Mata Ira was created by Maori researchers and really talks about Maori cultural ways and traditions and how this relates to genomic research. So I think just as genetic research technology and methods continue to advance, ethical models for engaging Indigenous communities should also advance beyond the standard ethical norms put forth in the Belmont Report and the Common Rule. So let's see. So in conclusion, I think that diversity in precision medicine and personalized medicine is lacking. I think that pharmacogenomics research is an opportunity to implement personalized medicine. And one example of this is in relation to smoking, nicotine metabolism, and cessation efforts of my lab. And I really think that ethical research approaches can enhance genomic research. And with that, I just want to say thank you to the Northwest Alaska Pharmacogenomics Research Network. Many thanks to the SING Consortium, as well as my funders. And also, if you are interested in working with me, I am looking for a postdoc, so please feel free to email me. Okay, thank you so much.
Thank you, that was great. I have a couple of questions I thought I would start with, and while I don't see any in the chat, please, if you have questions in the audience, post them in the Q&A or the chat. So I'm curious, so it seemed to me there was a little bit of a disconnect in some of the tobacco cessation stuff that you showed us, where you showed that in many of the native populations that you showed, they were fast nicotine metabolizers, faster than normal. And in the smoking cessation work, it was comparing slower than normal to normal. Mm-hmm. So the natural inference is faster than normal would be even more, towards the drug rather than the patch. But is there evidence that that's true, or is that just an inference?
So often the normal and fast metabolizers are grouped together just because of how trials have been created, and there's not really a clear distinguishing factor between or normal and rapid metabolizers. But yes, I think that a lot of studies do show that perhaps using varenicline and other types of oral medication might work better for the normal and rapid metabolizers.
Right. Well, so related to that, is there observational evidence in tribal communities, particularly the North Plains ones that seem to have the worst problems, that the oral medication works better than patches? Are there studies that look at effectiveness regardless of genetics?
I think that there have not been a lot of studies actually, because varenicline is sort of a high. Is not typically prescribed in many Indian health services settings. Often people will get actually the nicotine patch and maybe some counseling, but I think that as efforts are being made to really highlight the vast prevalence of smoking and the different causes, I think that this will become more important. So there are a few groups that are doing research with Indigenous communities on this topic, but definitely not many.
Interesting. And so why do you think that the drug is prescribed less in Indian health service settings?
I think it probably has to do with cost and access to that type of medication.
Oh, which circles into what you were talking about before, right? So the disparity, the pre-existing disparities in, money spent, among other things, is sort of running up against the evidence that it seems that one could infer. I guess it's not direct evidence that the oral medication could be more effective for those communities. Is that right?
Yeah, and I think that it also has to do with anyone trying to quit. There's a really high rate of people not quitting to completion. So I think that also comes into play, and just different cultural understandings and relationship with tobacco.
Sure. Yeah. Mark Twain's famous line about quitting smoking is easy. I've done it hundreds of times. All right. Let me see. I don't see anything in the. Oh, wait. Hold on. There's questions in the chat. So one of the questions is, does placebo work better than vernicline or nicotine patch? Would this mean that quitting cold turkey is the best approach?
Actually, well, some of the work that we've done, the placebos do horribly compared. I think using either the nicotine patch or varenicline is probably the best option.
Right. Yeah. Although it did look like the placebo did okay in that chart that you showed.
Yeah, and also I think other studies are looking at how cultural and traditional interventions could actually help with the rates of cessation in Native communities. So if you took a more cultural approach to counseling, maybe that would work a lot better.
Sure. Okay. And one more question. How does the variance explained of smoking cessation by CYP2A6 differ between indigenous populations, different indigenous populations?
Yeah, that's a great question. I think that not enough studies have been done. Really, there are only probably one or two studies looking at CYP2A6 variation and its relation to quitting smoking. And all of these are unpublished right now. So there's just not enough data out there. And no one has really looked at different indigenous populations in the U.S. So that's also some of the work that I'm hoping to do with a well-known cohort called the Strong Heart Study. So they have 12 tribes, 11 to 12 tribes that are involved in that study, and we can look at the past data just to see if any relationships arise between what was prescribed and were people able to quit smoking? So yeah, great question.